Good evening. I'm Dr. J.R. Rudzki. I'm an orthopedic surgeon at Sibley who specializes in shoulder surgery and sports medicine, and I'm excited to be here with you tonight. It's a different format we've been doing for the last couple of years because of the pandemic. Fortunately, with the vaccines and exciting news, I think we'll be back in person within the next several months, but hopefully we can collaborate and work together tonight. If you have questions, please use them in the chat and we'll do everything we can to address them. So this is a disclosure slide. I do consulting in the orthopedic realm as well as reviewing for orthopedic journals. The shoulder joint is the most interesting joint in the body because it has so many planes of motion and so little bony constraint. By comparison, the hip is a highly constrained deep ball and socket joint that has intrinsic stability from the bony anatomy. The shoulder has none of that. It's like a golf ball sitting on a tee sideways. And that's why we can do all of these things, reaching behind our back, throwing a ball, things we could never do with our leg and our hip because of impingement from the high degree of constraint. And it's a trade-off between mobility and stability. You have static stabilizers, which are the surfaces of the joints and the ligaments, and then dynamic stabilizers, the muscles of the rotator cuff and the shoulder blades. And these collaborate to give this balance between mobility and stability. The ligaments are these structural thickenings, and you want to kind of think of them like a dry fit shirt. The ones in the front tighten when I come back here to throw. The ones in the back tighten when I'm here to block. Those thicken over time and lead to motion restriction and pain, and they're a prominent component of arthritis. You'll hear about the biceps tendon variably, and some patients are told that they have disease of the biceps because it's quite common and everybody gets very nervous. The biceps is named bi because the muscle has two heads, one that goes outside the shoulder off a bony prominence on the scapula, and one that goes through the shoulder that looks like about a third of your small finger in width, or like a couple of fettuccine noodles. And that tendon travels in a bony groove between the two attachment sites of the rotator cuff, commonly has disease, and is of no consequence when you get to a certain age and it's diseased and painful. You can cut it, or you can cut it and tack it down and sew it into adjacent tendons and muscles, and it will heal and not be an issue. The important thing is not to ignore the biceps when it's a pain generator. The rotator cuff that we hear about quite often is 4 muscles with a common tendon, 3 on the top and the back that you see here, and 1 in the front called the subscapularis, which is interesting because it comes from the back underneath deep to the shoulder blade, runs through the armpit, and then comes over here to attach on the front, internally rotating and helping to stabilize the shoulder blade. Oh, hang on one second. We had the slides jump around there. So the rotator cuff is interesting because it's got muscles coming from the inside, coming off of the shoulder blade, and then attaching to the bone. And it is a source of disease and irritability for many people over time. With life, and with age, we see an increase in rotator cuff disease. So in this study that's now 26 years old, under the age of 60, there's a 4% prevalence of tears, but as we get over 60, it's about 28 to 30%, 65 to 70, 35 to 40, and when you get to 80, it's about 50% of the population or more. So the tears are incredibly common, and it's critical that we think of the etiology, meaning what caused the tear, and the biology for whether or not this is something that needs surgery, or is this something that's better served with rehab and exercises and physiotherapy. Rotator cuff disease is multifactorial. Stress and strain, as you see here on this slide on the left, and then impingement, which is a concept of the shoulder blade pinching down, which really relates to muscle balance around the shoulder, but also mechanobiology. We've sort of evolved in orthopedics to stop thinking on the gross big scale things of bones pinching on tendons, and we've started to really pay attention and look at the cellular level to see what's going on at the individual cells with tension, gene expression, apoptosis, which is pre-programmed cell death, degeneration, and changes of collagen composition with tearing and with time, as well as the immune system, which we know so much more about after the COVID pandemic. Matrix metalloproteinase expression is a type of immune-mediated inflammation around the joint and around tendons that can affect how they heal and how they degenerate with all of the stresses that we see here. And finally, the focus of my research in the past, which was looking at blood supply. Intuitively, we know that a 70-year-old is not going to have the blood supply of a 20-year-old. Well, that's an important component over time and why we get a progressive increase in stresses and strains that the body can't keep up with healing. The blood supply is an important part of that and something we want to consider when we look at etiology of what's causing tears and problems with the tendons. So this is research simply looking at that blood supply with a special injectable substance that we used, where you could get a Doppler ultrasound on the top left slide here, and then you could do an injection. And on the bottom two slides, you see that after the injection, the resolution of the actual individual blood supply in the tendon is much higher. You can then count the pixels of what's bright and what's dark here to quantify and extrapolate what's the individual blood supply. And this was work done at the Hospital for Special Surgery in New York. So if you sum up the research, patients under the age of 40, which are the green and blue, versus over the age of 40, have roughly double the blood supply of that group over 40. And that correlates with intuitively what we would think about what are some of the important factors in rotator cuff disease over time. And so moving on, we break rotator cuff disease down into two types: traumatic tears and degenerative tears. Traumatic tears are acute, injury related, have less retraction, minimal atrophy, and a higher likelihood of healing. Degenerative tears are chronic. They present insidiously. They are not injury related. There's something where a patient will come into the office and say, you know what, for the last 2 to 3 years, I've just had this sort of progressive irritability in my shoulder. I've had sort of progressively increasing discomfort, but it's not a, I slipped in a parking lot, I fell off a chairlift, I fell off my mountain bike, and now I can't lift my arm. These tears have atrophy potentially, and commonly they do, and they have a lower healing potential. So the tears on the left that we sort of have the smiley face are the smaller tears, the acute traumatic tears in patients under the age of 65 with less atrophy in non-smokers and non-diabetics. And the smiley face refers to the fact that these are tears that we can really do something about. These are tears that are reparable and have a high healing rate and are going to do quite well with surgery. The tears on the right side where you see the sort of sad face, these are the ones we want to avoid surgery for. These are the large to massive, really significant sized tears that are chronic and degenerative with atrophy in the muscles in patients over the age of 70 who smoke and have diabetes. Because when you take those factors together, we know from research that collectively they are going to lead to poor surgical outcomes with repair. And so we have to think about other strategies, whether it's physical therapy or other modalities. So how do we fix the rotator cuff tears? Well, the tendon bone attachment site is fascinating. And it's something we study in medical school when we do histology. It's a 5-layer transition where you have a muscle here coming into a tendon. And then as the tendon sort of welds to the bone, it's not just a spot weld, but a 5-layer transition zone for how it blends. And that's what you see in this slide here. This is a video here. And let me see. I think we're having some trouble with the pointer. Here we go. So we're just going to keep going. I think this is a Zoom casualty. Moving on to shoulder arthritis. If patients are interested in watching videos of arthroscopic rotator cuff repair, they can go to YouTube and put in J.R. Rudzki, MD, And there's a narrated video that I was going to show of an arthroscopic rotator cuff repair that shows you how we fix it with a high definition fiber optic video camera through 4 to 6 small poke holes less than a centimeter. So moving on to shoulder arthritis, which is really the bulk of our talk tonight. It's a degenerative condition of progressive cartilage wear characterized by inflammation, pain, stiffness, and motion loss. These collectively lead to impaired function. You have narrowing of the joint space from cartilage wear, bone spurs from cartilage wear, and articulation of bone on bone. And then the tightness of the ligaments I was telling you about before. So those ligaments classically are like a dry fit shirt with elasticity and flexibility. Over time, with progressive inflammation, they become stiff and tight. And instead of being like a dry fit shirt, they become like a canvas bag, and they restrict motion, which leads to additional pain. And that, in conjunction with the inflammatory process in the joint, the loss of cartilage, leads to erosion of the socket. So here you see a normal shoulder, and you see the joint space between the ball and the socket. Hopefully you can see this here with my pointer. And this is a normal shoulder. But now you're seeing the joint space is narrowing, and you see a bone spur here off the humeral head at the inferior portion of the head. Patients will ask me sometimes, well, doc, I really don't want a replacement. Is there any way we can just go in there with a camera and maybe shave down the bone spur? And the answer is absolutely you can, but it won't help you. It is of no benefit to arthroscopically go down and trim down that bone spur, because the spur happens as a result of the cartilage eroding and then now having bone rubbing on bone. The spur forms at the margin of the joint down lower. Taking that out doesn't change the bone rubbing on the bone, and so it's a surgery that we want to avoid. And then here you see deformity, where you start to see pancaking in this case of the humeral head. And finally, when you get what we call end-stage progressive arthritis, you get obliteration of the joint space, sclerosis, which is the hard white marbling of the bone that remains, a large bone spur here at the bottom of the humeral head, and a loose body here on top. So this is what we would call end-stage arthritis, which is characterized by significant motion loss, pain, what we call crepitus, which is noise, and you can hear and feel noise and grinding like a cobblestone street in the shoulder. And that's when we start to think about other interventions. So what are our options? Well, the mainstay to reduce pain and inflammation is anti-inflammatory medications, ice and activity modification, cortisone injections at time. And at one point we looked into synthetic lubricant injections. Unfortunately, the data really hasn't proven these to be sort of substantially effective, and they're not approved by Medicare. So there are some rare situations where we might try to use synthetic lubricant injections like we do in the knee, such as Synvisc or Gel 1 or Suparts. But those are situations for patients that are not a candidate for arthroplasty because they're too young. If you're 35 to 55 years old and you had a terrible motorcycle accident, and you have post-traumatic arthritis, we want to do anything we can to avoid replacing your shoulder until you're really, on your last leg, so to speak. If you are 70 and have a painful shoulder, synthetic lubricant injections are a waste of time. You try the other strategies, and once you get to a point where they're ineffective, then we talk about replacement. So here you see a patient who had replacement, and give me just 1 second because we got to reload this talk, and that'll just take me 1 second. Great, sorry for the interruption. And we'll pick off where we were. So this is the updated slide that I put in today. Hopefully you can hear this. But this is a patient who has end-stage arthritis here, where she's got bone on bone and she's got a bone spur and she's got significant functional impairment. And we do a replacement where we simply put a metal prosthesis to anatomically replace the ball with a stem going down the canal and a plastic socket here that's cemented in. Again, I think we're having trouble in this Zoom format with the videos. So we'll keep going. But this woman was a dancer, and it's unfortunate. I really wanted you all to be able to see this. She had full restoration. So beforehand, when she tried to dance, she could only bring her arm up to here. And then after surgery, she was able to bring it up to here and have full restoration of function, dancing, and her activities of daily living. This is a patient who is a 69-year-old male athlete right around the time of his 70th birthday, end-stage arthritis with profound motion restriction. We were able to replace his shoulder, and he broke 80 for the first time in his life, shooting 2 under par on the front 9 and winning this club championship in a member tournament, which we were really excited about for him. You know, this is why we do what we do. Patients will often ask, well, what kind of activities will I get afterwards? And it's common to be able to return to golf. Many can return to tennis and swimming. A lot of this is going to depend on how well you do with your rehab and how much deformity you have prior to your surgery. So there are over 50,000 shoulder replacements performed annually in the US now, and those numbers continue to go up with the baby boomers approaching this age. The goals are pain relief and optimal shoulder function, and the technical points are to restore the anatomy of the proximal humerus, which is the top of the arm, and the glenoid, which is the socket, and then to balance the soft tissues around the shoulder. So going back to essentially 20 years ago, we see that this has been a well-established procedure that provides substantial functional improvement. And in this study by Mattson, who was one of the real thought leaders in shoulder out at University of Washington in Seattle, patients had a 94% functional improvement. On average, patients regained 2/3 of the functions that they didn't have before surgery. They had a 73% chance of regaining a function that was absent before surgery, and their chance of losing a function present before surgery was 6%, which are good results. And I think we continue to improve on these, and we'll talk about strategies to make that better every year. So when we compare this to partial replacement or hemiarthroplasty, hemiarthroplasty continues in the background to be discussed in some circles for certain specific patient populations, but in summary, I would tell you it's a really suboptimal procedure. By only replacing one side of the joint, you only treat essentially half of the disease of the shoulder. It's an easier operation to do, but it is significantly less effective in providing meaningful pain relief. So this is sort of what we would call bread and butter, straightforward shoulder replacement. This is a 79-year-old female. She has bone-on-bone arthritis. And what I want you to notice here on this, what we call axillary lateral that's coming up through the armpit, is that she has concentric arthritis of her shoulder. The ball is not translated posteriorly. The socket is flat in relation to the line of the shoulder blade or scapula. There's no erosion of significance or deformity here, so this is an easy case. Her MRI shows that she has a normal rotator cuff. She's failed anti-inflammatories and injections and has severe pain. And so she gets a replacement. We anatomically replace the shoulder, remove the arthritis, and put in a plastic socket with a metal prosthesis. And she has an excellent result with that. And she's able to get back to full function. So we want everybody to be this easy and this simple and do this well. I can't say that's the case 100% of the time, but we're pretty fortunate to have good results with what we do. And that comes from years of study and focusing on how to refine our techniques. Many patients are now familiar with the reverse shoulder arthroplasty. And what you'll notice in comparison to here, where we kept the ball on the humeral side and the socket on the scapular side, the reverse simply flips those around. And so you have a ball here on the scapula or socket side, and then you have a socket or a cup on the humeral side. The reason for that is there are certain types of injuries and deformities and conditions where the rotator cuff is deficient, where you can't keep the head centered in the socket. And in that circumstance, if you flip these and put a cup around a ball, hence the reverse term, the deltoid muscle, which comes off the shoulder and attaches on the humerus here, can power this for elevation. So in the x-ray picture you see on the left, this is a woman who had a severe proximal humerus fracture, a terrible fracture of the shoulder. And because of smoking and poor bone density, this was not something that was amenable to fixation. So by replacing her shoulder, we could have an excellent result. And again, unfortunately, we're just not able to watch her video. But she had full restoration of motion, and you can see she can lift up, and she actually has full internal rotation and can come here and throw a ball. Again, I'm sorry about the videos not coming through, but I look forward to us being able to meet back in person in the future. So reverse shoulder arthroplasty is also a very powerful tool for deformity. Not all shoulder fractures need surgery. Many of them will heal in the ballpark and actually do quite well over time. This is an example of that with a woman who is approximately 78 to 80 years old. She had a fracture about 15 years earlier that was treated conservatively and did well for about 13 to 14 years. Unfortunately, over time, she developed progressive arthritis, insufficiency of her rotator cuff, and she had what's called a malunion, where this is not a normal shoulder. But with a reverse shoulder replacement, we're able to reconstruct it and get her motion back so that she can brush her hair and lift her arm up and live her life. Again, this is a video that I really wanted you all to see. The point of this patient's discussion after her surgery is that she had arthritis on both shoulders. And by focusing hard on her physical therapy after her surgery on the left, she found that she had one good arm. And so even though she had residual arthritis on the right, she didn't need to worry about having a replacement again right away. She might decide to do it later on down the road. But even just doing one shoulder sometimes empowers patients to have a good sort of working arm for daily activities, which lessens the load on the other arthritic shoulder. And I think that's an important thing that we discuss in the office with patients. So some of the technical aspects of how we do it: regional anesthesia in the beach chair position. We wear spacesuits in the operating room, and that helps to create an ultra sterile environment. Some of that is slightly being modified by some new techniques we're using. Patients will put benzoyl peroxide, or essentially like a Clearasil-like material, onto their skin before surgery to reduce a type of bacteria that can be a problem with shoulder replacements that's inside the skin. You get intravenous antibiotics. I scrub your skin, the nurses scrub your skin, I scrub your skin again. We wrap you in this special betadine impregnated tape to keep a sterile field. And then we irrigate the field with a combination of saline and betadine and copious saline. And all of these strategies, in addition to putting antibiotic powder in the wound at the end of the procedure, help to reduce the risk of infection to the lowest possible number. It's never going to be zero, but we can reduce it to the lowest possible number, which at our institution for shoulders is approximately 1% in my experience. So moving forward, the incision here is how we approach a shoulder, and it's basically working through this plane or interval between the deltoid muscle laterally to the outside of the shoulder and the pectoralis here on the inside. And we can dissect through there and literally open the door to the shoulder. We then come down to this tendon that I told you about before called the subscapularis in the front, and we will either cut through the tendon, peel the tendon, elevating it off, or cut a small sliver of bone and allow that to help elevate the tendon. And collectively, that gives us access or opens the door into the shoulder. So we then will carefully dissect the capsule off the neck of the humerus, bring the humerus out of the body, kind of into the wound by elevating it forward, putting retractors in and removing the bone spurs that you saw on those x-rays. And then we make what we call an anatomic neck cut, resecting the arthritic humeral head right at its base. And then we turn our attention to the glenoid. And this is a very important part of the procedure. This is where we're going to put retractors, release the capsule, and expose the socket. And this is what that socket looks like here. And hopefully you can kind of see that on the camera. So we put retractors in the back and the front, and inferiorly protecting a nerve that runs down here at the bottom. But what's really interesting is that sockets come in all different kinds of shapes and sizes. So this is one patient's socket, which if you look at my thumb is, you know, a fairly enormous shoulder in a guy who had bad arthritis with a big bone spur here. And we use technology that I'll show you shortly with a CAT scan that gets three-dimensionally digitized to create this sterile printed three-dimensional model that I have with me in the operating room, and then an individual patient-specific guide that clips on to the patient's anatomy like you see here and tells me exactly where to put the guide pin to center my component and to do the operation. And that's on a very big one, right? So this is a big socket and a big guy with big bad arthritis. But what about our patients that are smaller, right? We have some petite female patients, and this to me is really interesting and illustrates how different our patients are. So this is not a one-size-fits-all operation. This is something that requires a great deal of attention because I have a lot more room to place my components here. I still need to put it in the right place, but the consequences for being a millimeter or two off in a socket this small are really significant. And that therefore would benefit from additional preoperative planning and the technology that's evolved. So when I get to this shoulder, I put my guide on, and again, it tells me exactly where I'm going to put my pin. Or similarly with this other system, I have my socket, and then I have a guide that clips on and when it clips in, it tells me exactly where I'm going to put my implants. And so this enhances the precision of what we're doing based off of our CAT scan. So each individual operation is tailored for that patient's deformity and their own individual anatomy. This is an example of what we're talking about here, how we prepare the glenoid, how we prepare the humerus by reaming down the canal. People ask me like, well, how do you put the components in, or how does that work? And the answer is you take the canal or the shaft and we put reamers in, and then we have broaches that create a path, and then we impact the stem in. If the patient's bone density is poor, then we'll use cement to help augment the fixation, and that's just a patient-specific thing depending on the quality of their bone. So this is an example of a patient. Again, unfortunately, I don't know that we're going to get his video firing today, but he was an 80-year-old male, had end-stage arthritis, had a shoulder replacement, full function, got back to doing push-ups. He was 80, and I said, look, I really don't want you doing push-ups. And 10 years later, I saw him in the office, and he's able to work in his yard and live with his shoulder, and it's durable and happy, and that's pushing 90. So another example here, this is where arthritis starts to get a little bit more complex. The erosive deformity of the humeral head and the posterior translation of the humeral head make for a slightly different animal. And so again, this is just simply data talking about partial versus total shoulder replacement. If you compare the two, partial replacement is more likely to have a revision because of incomplete pain relief. And so we try to avoid that and do a total shoulder replacement for these patients. So what are the problems with shoulder replacement? Well, it's glenoid loosening. When you do an anatomic regular ball and socket replacement, glenoid loosening can be a problem, and longevity then is a problem. So we try to manage patients conservatively for as long as possible for a number of different reasons. This glenoid loosening can happen both with metal-backed components or with cemented plastic polyethylene components. And we're constantly evolving our research and trying to affect where we position our components and how can we preserve as much bone as possible to get components that last longer on the socket side, because they're subjected to all different kinds of loads when we push up from chairs, when we do work in the yard, when we use our arms after the replacement. So this is just simply talking more about glenoid loosening and illustrating that and the problems of decreased longevity in certain cases and for a variety of different reasons that we pay attention to with our surgical planning. So when we talk about glenoid erosion, this is where a concentrically arthritic shoulder, the ball is going to stay centered in the socket. But what happens in many cases is that the ball starts to go out the back and erode the socket or tilt it, as you see in this scan here. The posterior portion of the socket is eroded and has actually created a new glenoid. An entire classification of this was developed by a brilliant French surgeon named Gilles Walsh, and it categorizes the formation of a new glenoid during the arthritis, where the old glenoid doesn't even see the humeral head anymore. And as you see here, if you draw this line, over 50 to 60% of the humeral head is actually out the back of the shoulder. So in these cases, the anatomy is distorted. This can cause laxity of the soft tissues, and it requires more careful procedure and strategies to address that. Here is a nice three-dimensional CAT scan from an article showing that if you don't have concentric arthritis with a glenoid that's flat and perpendicular to the scapula, but rather like this, it can be awfully challenging to get that component to seat right. And I liken this to landing a plane on an aircraft carrier when it's listing 30 degrees to starboard, right? That's going to be a challenge for how you're going to get things seated and not have it slide off or have problems. So we identify this by looking at plane films, but really what we do now is look at an MRI and a CAT scan, and that the CAT scan helps us significantly for how we can digitize this and then plan our surgeries. So patient-specific instrumentation is this technology by which we take that digitized three-dimensional CAT scan and enhance accuracy by manipulating it. So we basically study each individual patient before their surgery and plan it like a flight path, right? And so if you think of it like a military mission, or you think of it like any other strategy you would do architecturally to try to build or design something, we have the opportunity to model it on our computer at home and on our own terms decide, well, what component would fit best here, and what strategy, and what company should I use, and which implant is going to likely have the best fit while preserving the most amount of bone and then have the highest chance of stability and restoration of motion. So that's just a phenomenal benefit. And what I'm really excited about, I'm part of a small group of surgeons right now that is access on a limited release to virtual reality technology, or what we call mixed reality. And this is a special pair of goggles that you wear in the operating room, and you can see them here on the right and here at the bottom where we're doing a shoulder replacement. And they actually project a hologram on the surgical field. And what that does is enable everyone on my team to see what I'm looking at as I'm doing the surgery, but also to see what I'm looking at with the plan that we made on the computer before surgery. And so you'll see several images here. This is an example of what I showed you with the 3D printed guide. This is the guide wire into the patient's shoulder here. And this is the hologram showing what my plan was of what I wanted to do before surgery. Here's my CAT scan of the patient, and I have access to all of this by simply moving my hand in space and touching and manipulating these things to enhance the precision without looking away from the surgical field or doing anything different. I'm simply focused on the operation, but with a 5-degree tilt of my head, or even my eyes moving 10 degrees, I can see, okay, that's exactly what I planned. Or, you know what, this looks a little bit different. How are we going to address that? This is a phenomenal tool to enhance the teamwork that we have in the OR. Here you can see the CAT scan in the box right here. Here you can see a clone image of the plan. And then here you can see a 90-degree flipped view of the plan that I can manipulate in space with my fingers with sterile gloves on as I'm doing the surgery. And I can be precise about where I'm going to put the components. This is in its sort of early stages, but it's already live and something that we're using at Sibley and that we're really excited about. And I think categorically, this is going to be the future of surgery. It's just a question of how does the technology evolve precisely and how much power does it acquire over time. Here's another example where I can take those other views that you saw that were opaque, and now I can make it translucent and show exactly where my screws are going to be to get fixation of the base plate for this reverse shoulder arthroplasty. So it's fun to talk about all the great things that we can do and to show people winning golf tournaments and breaking 80 for the first time, but nothing's perfect. There's always a risk of complications. Historically, the statistical risk of complications is approximately 5% with shoulder replacement. I think we do a bit better than that, but nonetheless, nobody has a 0% complication rate. They include infection, glenoid erosion, and loosening, like we were talking about, which is socket-sided failure, failure of repair of that subscapularis tendon that we have to go through in order to get access into the shoulder, problems with the attachment sites of the rotator cuff, particularly in cases of fracture, and injuries to the rotator cuff, the nerves, and the vessels around the shoulder, as well as other potential complications like blood clots, pneumonia, and other problems. So we've talked a bit about the reverse total shoulder arthroplasty. This is a slide that I have in from about 5 to 10 years ago, but the reason I like to keep it in is 14 years ago, the reverse was studied and found to be very effective, but at that time had a 12% complication rate and a higher infection rate. Over time, we've been able to reduce that and make that complication rate just above total shoulder arthroplasty. And depending on the individual specifics of the patient population, I think it's absolutely equivalent to an anatomic shoulder replacement. So, you know, the reverse shoulder arthroplasty has now been around for quite some time. It's really been in one form or fashion around for over 30 to 40 years, but it sort of disappeared for a while as it went through mechanical improvements and refinement in the technique, came back in about 2005, 2006. And for the last 15 to 16 years, we've had progressively improved results with it that have enabled us to treat a broad spectrum of patients with very difficult problems that have rotator cuff deficiencies, significant bony erosion, fractures that are unreconstructible, and other problems. And we can restore function and relieve pain with this procedure, which really makes it something extraordinary. Nevertheless, this reverse prosthesis is reserved for treatment of disabling shoulder arthritis and arthropathy, which is pathology of the shoulder with rotator cuff insufficiency. And for these authors, it should be used exclusively in patients over 70 years old with low functional demands. I think we realize now that the operation is more powerful and we can do it with moderate functional demands, but certainly not something we want to use for high demand people. And we really would like to keep the cutoff for me at about 70, but occasionally there might be a patient who's 68 and for one reason or another, it simply makes sense as the most appropriate operation for them. But that's something you should discuss with your surgeon. So this is simply another follow-up study talking about sustained improvement in functional outcome scores and range of motion at 10-year minimum follow-up. All right, here we have a video.
Tell me what you just said about your shoulder.
I had my shoulder for 2 years. I highly recommend it to anyone. It feels like my old shoulder. It's nothing I can do, no which way I can't move. It feels very natural and normal.
Let me see you lift it up. Okay.
I can go behind my back, out to the side, any which way. It doesn't hurt.
Looks great.
All the way.
So glad to see.
Yes.
So a nice case example of somebody who's happy with her reverse. And this is a patient who has rotator cuff arthropathy, meaning that her rotator cuff is incompetent. She had a failed repair performed previously. She has no space here because the rotator cuff is torn and retracted. The shoulder is arthritic, it's articulating high, and with a reverse shoulder replacement, we're able to reconstruct it and restore function and pain relief. These patients are not functionally normal. You know, it's important to understand. It's not that we can make them perfect and they can throw a ball, but they can frequently elevate their arm and certainly elevate it better than before surgery to a functional level, and they can use it for activities of daily living. I don't want them operating heavy machinery. I don't want them doing like vigorous, heavy, aggressive gardening, but they can certainly work with potted plants, and they can cook and shop and do work around the house and clean and travel. And for the right patient who has significant disability, difficulty, and pain, this is an excellent operation. This is a different example of somebody who came to Washington. Their kids brought them up from Texas because they had malunion. So this is, you can see a displaced fracture. It's months old, it failed to heal and has led to pain and disability. And by doing a reverse shoulder replacement, we can simply restore function so the patient can use their elbow and hand. They can elevate their arm to about 90 degrees. It's far from perfect, but it's functional for them to improve their quality of life significantly. This is an 82-year-old patient who I operated on now approximately 8 to 10 years ago, and she was a really special patient. She had a radical mastectomy approximately 40 to 50 years ago. So this was back in the days where they not only took the breast tissue, but they took the entire chest wall tissue of muscle and soft tissue envelope. So the pectoralis and the associated musculature coming all the way down to the shoulder joint were all removed because of the time in which she had the surgery, which was now 40 to 50 years ago, and maybe even 5 or 7 years more than that. So over time, she developed progressive arthritis and deformity with severe pain, and that actually made her lymphedema worse because it was sort of blocking the egress of fluid out of her arm. So this was a higher risk surgery because when you don't have the pectoralis muscle here and you make your incision, you're at a higher risk of infection and complications and problems. But we discussed that with her and her family, and we're able to work with the lymphedema team at Sibley and get her into therapy. So here you can see sort of the deformity that she has preoperatively and the significant lymphedema she has down in her arm. And we were able to do a reverse shoulder replacement for her and get her hand back to normal. And so, you know, this was one that we were really happy about, and she didn't get an infection. We were able to carefully manage the soft tissues, and for her it was a significant benefit. So thank you for your attention. I think we're, you know, getting to that time. Please reach out with any questions. Kathy, do you have anything for me?
No, it seems like there is one question in the chat though.
Okay. Yes. This patient says, have shoulder replacements improved over the last 5 years to the degree that someone with a frozen shoulder due to an incompetent rotator cuff could expect improvement in function after the procedure? And the answer is yes. Obviously, you need to be examined, and someone needs to look at your history and make sure that you're an appropriate candidate, but you're precisely somebody who should benefit considerably from a reverse shoulder replacement. The term frozen shoulder is probably inappropriate when you have arthritis due to an incompetent rotator cuff. That's really cuff tear arthropathy. It feels frozen and it seems frozen, but it's frozen for a different reason. It just didn't freeze out of the blue idiopathically like other people's frozen shoulder. It froze because it has arthritis and it has dysfunction. And so in that setting, just like we do surgically, we release the capsule and we address the arthritic changes that are happening there, and then we do a reverse shoulder replacement. And if you're the right age and the right candidate, it can be very helpful for you. But obviously that requires specific, you know, examination and attention to your individual details. Any other questions? I see an old friend in the audience. Can you chat your question? Kathy, do you see any more?
Someone raised their hand, but I could not see who that was. Two participants have raised their hand, but if they could type into the chat or the Q&A section, that would be more helpful. I can't.
Yeah, if you click on more on your screen, there's a little thing that says chat. And if you click chat there, you should be able to type a question.
Oh, she said that raised hand says, not a question, just a comment. Very happy with the surgery. Very happy with the surgery.
Well, thank you, sir. It's nice to see your name pop up. This patient is an old friend now. We know each other well, and I had the pleasure of taking care of his shoulder, and I'm glad you're doing well. Any other questions or comments? Again, thank you for bearing with me. I'm glad we got to watch at least one video. I'm sorry for some of the others, but as I said, I'm optimistic that we're going to be back in person soon. And when we are, it'll be nice to meet and be able to have a more collaborative sort of engagement where you can ask questions and put your hand up at any time, and we can really dynamically discuss these things. And hopefully that'll be in the next couple months. So I wish everybody well, and if there's anything we can do for you, please let us know. Kathy, thank you so much.
You're welcome.
Have a good night, everybody.